Hi all, I am Sabriya, a second year MBBS student, Karwar Institute of Medical Science. Today I am going to present a seminar on carcinoma esophagus. I will be presenting this seminar under the following headings: Introduction, Epidemiology and Risk Factors, Types of Esophageal Carcinoma, Etiology, Pathogenesis, Morphology, and Summary. Carcinoma of the esophagus is one of the most aggressive malignancies of the gastrointestinal tract and is associated with high morbidity and mortality due to late diagnosis and early spread. It commonly affects older individuals and occurs more frequently in males. Before getting into the topic, let me explain the basic anatomy of esophagus. Esophagus is divided into three regions: upper third, middle third, and lower third. Normally, it is lined by stratified squamous epithelium. Epidemiology. Esophageal carcinoma is commonly seen in individuals between 50 and 70 years of age and shows a higher incidence in males than in females. The disease has a distinct geographical distribution with high incidence regions including China, Iran, South Africa, and Central Asia. In India, squamous cell carcinoma is the predominant histological type. Classification. The two major histological types are squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma is commonly associated with smoking and alcohol consumption, while adenocarcinoma is strongly linked to gastroesophageal reflux disease and Barrett esophagus. Squamous cell carcinoma is most common worldwide and it arises from squamous epithelium. Adenocarcinoma is common in Western countries. It is usually associated with Barrett esophagus. Gross types are fungating, ulcerative, and infiltrating. Squamous cell carcinoma. Squamous cell carcinoma is the malignant neoplasm of the esophagus showing squamous differentiation. Most common type of esophageal cancer in India. Etiology. Major risk factors are high alcohol intake, tobacco smoking, nutrition, poverty, diet deficient in vitamins and certain trace elements, polycyclic hydrocarbons, nitrosamines, fungal toxin, etc. Hot beverages, frequent consumption of burning hot beverages which causes thermal injury. Other etiological factors are caustic esophageal injury, Plummer-Vinson syndrome, achalasia cardia, celiac disease, previous radiotherapy to the mediastinum, and human papilloma virus infection in high risk areas. Spread. It mainly spreads through three routes: local spread, lymphatic spread, and hematogenous spread. Local spread into respiratory tree, aorta, mediastinum, and pericardium. Lymphatic spread into regional lymph nodes, cancer in the upper third to cervical lymph nodes, middle third to mediastinal, paratracheal, and tracheobronchial nodes, lower third to gastric and celiac nodes. Hematogenous spread, it occurs late to liver, lungs, adrenals, kidneys, and bones. Pathogenesis of squamous cell carcinoma. In squamous cell carcinoma, carcinogens such as smoking, alcohol, fungus contaminated food, and sometimes HPV infection cause repeated injury to the esophageal squamous epithelium, leading to DNA damage. This results in molecular abnormalities such as amplification of the SOX2 gene, which promotes cancer stem cell survival and self renewal, and overexpression of cyclin D1, which increases cell proliferation. There are also loss of function mutations in tumor suppressor genes like TP53, E-cadherin, and NOTCH1, causing loss of growth control, decreased apoptosis, and reduced cell adhesion. These genetic changes produce squamous dysplasia, which progresses to carcinoma in situ and finally invasive squamous cell carcinoma after breaching the basement membrane. Clinical features include dysphagia, odynophagia, which means pain on swallowing, and obstruction. It is insidious in onset. Morphology. Half of the squamous cell carcinomas of esophagus occur in the middle third, followed by lower third and the upper third of the esophagus. Grossly, three types of patterns are recognized: polypoid fungating type, ulcerating type, and diffused infiltrating type. Polypoid fungating type is the most common form. It appears as a cauliflower-like friable mass protruding into the lumen. Ulcerating type is the next common form. It looks grossly like a necrotic ulcer with everted edges. Diffuse infiltrating type appears as an annular stenosing narrowing of the lumen due to infiltration into the wall of esophagus. The given figure shows the gross appearance of squamous cell carcinoma. The arrow shows concentric circumferential thickening in the middle, causing narrowing of the lumen. Microscopy. Most tumors are well differentiated or moderately differentiated. Features commonly seen are prickle cells, keratin formation, keratin pearls. Malignant squamous cells invade the underlying stroma. Intercellular bridges may be present. In some cases, non-keratinizing pattern, anaplastic or poorly differentiated pattern can occur. A special variant called verrucous squamous cell carcinoma is also seen, which is exophytic, slow growing, and extremely well differentiated. Coming to the next histological type, adenocarcinoma. Adenocarcinoma is a carcinoma displaying glandular differentiation and usually arise in a background of Barrett esophagus and long-standing gastroesophageal reflux diseases. Etiology. Major risk factors are GERD leading to Barrett esophagus, obesity, scleroderma, diet deficient in fruits and vegetables, diet rich in animal fat and cholesterol. GERD or gastroesophageal reflux disease is a major etiological factor leading to adenocarcinoma. It is a condition in which gastric contents reflux into the esophagus due to incompetence of the lower esophageal sphincter, causing symptoms and mucosal injury. Barrett esophagus is another etiological factor. It is a condition in which, due to reflex esophagitis, stratified squamous epithelium of the lower esophagus is replaced by columnar epithelium, columnar metaplasia. Pathogenesis of adenocarcinoma. Chronic gastroesophageal reflux disease cause repeated exposure of the lower esophageal mucosa to acid and gastric contents, resulting in chronic inflammation and mucosal injury. To adapt to this persistent injury, the normal stratified squamous epithelium of esophagus is replaced by intestinal type columnar epithelium containing goblet cells, a condition known as Barrett esophagus. This metaplastic epithelium is more resistant to acid but is genetically unstable and prone to malignant transformation. With continued injury, the Barrett epithelium undergoes progressive dysplastic changes, beginning with low grade dysplasia and later high grade dysplasia. During this progression, several genetic abnormalities develop, including mutation or overexpression of the p53 tumor suppressor gene and amplification of oncogenes such as ERBB2, cyclin D1, and cyclin E, which promotes uncontrolled cell proliferation. Epigenetic changes such as hypermethylation and silencing of P16 or INK4A tumor suppressor gene also contribute to loss of growth regulation. Accumulation of these alterations finally results in invasive adenocarcinoma of esophagus. Clinical features: pain or difficulty in swallowing, chest pain, progressive weight loss, hematemesis, or vomiting. Morphology: it is usually seen in the distal third of esophagus. Early lesion appears as flat or raised patches, later infiltrate diffusely or ulcerate. Microscopically, adenocarcinoma of the esophagus can have three patterns: intestinal type, adenosquamous type, and adenoid cystic type. Intestinal type is the adenocarcinoma with a pattern similar to that seen in adenocarcinoma of intestine or stomach. Adenosquamous type is the pattern in which there is an irregular admixture of adenocarcinoma and squamous cell carcinoma. Adenoid cystic type is an uncommon variety. It is akin to similar growth in salivary gland, that is, a cribriform appearance in an epithelial tumor. To summarize, carcinoma esophagus is a malignant tumor arising from the epithelial lining of the esophagus and is one of the most aggressive gastrointestinal cancers because it is usually detected late. The two major histological types are squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma is more common in India and usually affects the upper and middle third of the esophagus, whereas adenocarcinoma commonly affects the lower third near the gastroesophageal junction. The major risk factors of squamous cell carcinoma include smoking, alcohol consumption, nutritional deficiencies, nitrosamine rich food, consumption of very hot beverages, achalasia cardia, Plummer-Vinson syndrome, and corrosive strictures. Adenocarcinoma is strongly associated with gastroesophageal reflux disease and Barrett esophagus, where the normal stratified squamous epithelium is replaced by intestinal type columnar epithelium. The pathogenesis of squamous cell carcinoma involves chronic irritation leading to dysplasia, carcinoma in situ, and finally invasive carcinoma. Important molecular changes include TP53 mutation and cyclin D1 overexpression. In adenocarcinoma, chronic GERD leads to Barrett esophagus, followed by dysplasia and malignant transformation into adenocarcinoma. Grossly, esophageal carcinoma may appear as fungating, ulcerative, or infiltrative lesions. Squamous cell carcinoma commonly forms ulcerative or infiltrative masses in the middle third, while adenocarcinoma usually presents as a lesion in the distal esophagus. Microscopically, squamous cell carcinoma shows malignant squamous cells with keratin pearl formation, intercellular bridges, pleomorphism, and increased mitotic activity. Adenocarcinoma shows malignant gland formation with mucin production and infiltrating atypical columnar cells. The tumor spreads locally to surrounding structures such as the trachea, bronchi, mediastinum, and aorta. Early lymphatic spread is common because of the rich lymphatic drainage of the esophagus, and distant metastasis commonly occurs in the liver, lungs, and bones. Clinically, the most common symptom is progressive dysphagia along with weight loss, odynophagia, chest pain, and hoarseness of voice. Diagnosis is mainly by upper GI endoscopy and biopsy, which is the gold standard. Important complications include obstruction, malnutrition, aspiration pneumonia, fistula formation, and metastasis. Overall, carcinoma esophagus has a poor prognosis due to late presentation and early spread, but early detection and treatment can improve survival. Thank you.